Hi, and welcome back. I hope you enjoyed your lunch. I certainly did. Welcome to this afternoon session. I'd like to introduce Michael Farrell, who should be our chair for the first afternoon session, which is looking at how do we know we're doing what we want to be doing. A session on outcomes and data. Thanks, Michael. Over to you.
Hi, thanks very much, Krista, and my best wishes to everybody in this seminar. There's been a very interesting presentation so far, reflecting a wealth of research activity taking place across Australia with the support from NCCRED. To start off the session this afternoon, which is looking around the issue of clinical measurement in the context of methamphetamine problems, we have Emma Black talking on detailing a clinical data laboratory for methamphetamine use in New South Wales, the MAD Data project. So over to Emma.
Hi everyone, I'm here today to talk about our project, the MA Data project, which looked at client characteristics at entry to treatment with a focus on amphetamine type substances. We had three main research questions for this component of the project. We started by looking at ATS as principal drug of concern, and we compared characteristics of clients who were seeking treatment for amphetamine use with those seeking alcohol, opioid and cannabis treatment. We then moved to look at ATS use among everybody who came to treatment, regardless of their main drug of concern. And then we ran a multinomial regression to see which client characteristics were associated with frequency of amphetamine use. We used the ATOP and MDS data, and by treatment entry, we mean an assessment ATOP was completed. So the ATOP is a clinical tool that records information about drug use and social conditions over the preceding 28 days and is used across a number of treatment settings in Australia, including within several New South Wales local health districts. We included people who had entered treatment over a 3-year period across 6 LHDs, and we had around 14,000 people's records that were eligible for analysis. So just to summarise the client's characteristics by principal drug of concern, here are the demographics for the 4 principal drug of concern groups. So people whose PDOC was ATS were typically in their mid-30s, mainly male, English-speaking and Australian-born. They're slightly younger than people with alcohol and opioids as PDOC, and they're older than people who come in for cannabis use. But there are some variations, particularly some sex differences, and in the proportions of First Nations people across the different groups. This slide summarises the ATOP items grouped by principal drug of concern. People with ATS as their principal drug of concern are shown in the top right-hand box with the darker orange bars. These results show that people with ATS as their principal drug of concern tend to report many stresses and disadvantages, particularly when compared to people seeking alcohol and cannabis treatment. These include only 25% reporting that they're engaged in any work or study, and 1 in 5 or 21% who report housing stress. Also, people with ATS as their principal drug of concern also report the highest rates of violence, both as perpetrator and victim, and they have the highest rates of recent arrest of these 4 groups. Now this slide shows the proportions reporting any use of the main drug classes, again grouped by principal drug of concern. So as we might have expected to see in these data, polysubstance use is common among people who present for amphetamine treatment, as it is among people coming in for opioid, as it is also among people coming in for opioid treatment. It's less common among people seeking treatment for alcohol and cannabis use. And before I go on, I'd just like to explain that we've split amphetamine use into 3 categories here. This is based on previous work, which has found that it's meaningful to do this with these groups. And the groups are high frequency use, which is 13 days or more, up to 28, low frequency use, which is between 1 and 12 days, and no use of ATS. So this slide shows the frequency of ATS use among these 4 groups. The purple bars show the proportion who did not use any ATS in the 4 weeks prior to treatment entry, and the green and orange bars show who had used ATS, green for low frequency and orange for high frequency. As you can see, there are people across the treatment spectrum who use ATS, and some of them do so quite regularly, particularly in the ATS as principal drug of concern group, as you might expect, but they do exist in the other groups as well. And another point I'd like to make from this is that a third of people presenting for ATS as their principal drug of concern had actually not used any at all in the past 28 days. So moving on from principal drug of concern to looking at everybody who had used ATS. This slide combines all clients at treatment entry, regardless of their principal drug of concern, and it shows that a fifth had used amphetamines in the 4 weeks before their assessment. And around 1 in every 15 clients coming into services has been using them at a high frequency. These are the demographics for the 3 groups. Not a lot of surprises here really. They're mainly male, in their 30s to perhaps early 40s, mainly Australian born and mainly English as preferred language. And here's how they looked on their ATOPs. So again, the purple bars represent the people who had not used any amphetamines in the past 4 weeks. The green represents the people who had used at low frequency, and orange is the high frequency users. It looks very much like there's a dose response here, with the people who use the most reporting the greatest amounts of stress. But we'll have a look at this relationship in more detail in the regression in a moment. In terms of their substance use, there's less of a dose response pattern here. People who use ATS tend to use less alcohol and more of the other substances than people who don't use amphetamines. And it doesn't really change a lot according to whether they use amphetamines at a low or a high frequency. So then we ran a multinomial regression to examine whether there are statistically significant differences between clients according to their frequency of amphetamine use. For this, we used all the records where we had complete data. So that was 72% of the overall sample that I've just been describing. And the outcome variable in the regression was whether the person was in the no, the low, or the high frequency use ATS group. And we included 20 predictors or independent variables. Here are the results. So the predictors are listed down the left-hand side, and across the top are the comparisons. I just started here with the low frequency use and compared it to no use. So a tick means there's a significant difference between the 2 groups on this variable, and they're color-coded according to the level of significance. You can see here that there are many differences. People who use ATS at low frequency are younger, more likely to be male, experience more housing stress, are less likely to be living with children, and are more likely to have injected compared to people who haven't used ATS. They drink and use opioids less often, and they use cannabis more often. They also report poorer psychological health and poorer quality of life than people who don't use amphetamines. When comparing the high-frequency ATS use with people who hadn't used ATS, the pattern of results was broadly the same, although there was no sex difference between the 2 groups at this time. And now, when you compare the high-frequency to the low-frequency ATS use groups, there are far fewer differences. However, people who use ATS a lot are more likely to be women, to have been arrested, to have used opioids outside of an opioid treatment program, to have used cannabis on more days, to have injected, and to have a lower quality of life compared to people who use ATS at a lower frequency. So just to summarise, Firstly, the data show the extent to which people entering treatment use ATS, which overall is fairly common. So we can't just rely on principal drug of concern to try and understand this population. Secondly, just under a third of people attending for amphetamine treatment haven't actually used them in the past 4 weeks. Thirdly, people who use ATS are often experiencing stress in a variety of areas, including housing stress, arrest and violence, and they report poorer psychological health and quality of life. Fourth, while there isn't a consistent dose response across all social conditions, as the graph earlier kind of suggested, there does appear to be a dose response across some factors. In our regression, we found that the more often a person had used amphetamines, the more likely they were to report recent arrest, injecting and cannabis use. And they also reported lower quality of life and lower levels of alcohol use. Fifth, there are some sex differences in ATS use, with women, when they do use ATS, tending to use them more often. And of course, this is a discussion around correlation. It doesn't give any indication as to causation of this situation. And although this is quite well known as well, we do need to highlight that disproportionate numbers of Aboriginal and Torres Strait Islander people are represented in our services compared to the relative number of First Nations people in the general population. We should also mention that the relevance of considering parenting support and child protection issues for clients who live with children. We should note the extent of benzo and cannabis use among ATS users because, again, although this is not surprising, it is good that we can document this in such a large sample size and across a number of different LHDs in different settings. And there also appears to be a rule of thirds among people seeking ATS treatment in terms of their use frequency. Thank you very much for your time. Please don't hesitate to get in touch if you have any questions at all.
Thanks very much, Emma Black. We now move on to Lou Mills, who will talk about the impact of amphetamine-type stimulant use on clinical outcomes in OTP clients.
Hi everyone, my name is Lou Mills and I'm a postdoctoral researcher working with the research team at the Langton Centre. This analysis was performed for the MAD Data project, part of a grant awarded by NCCRED. So I'm going to refer to amphetamine type substances, or ATS, as amphetamines throughout this presentation because I think acronyms can be a bit opaque sometimes, but just know that when I say amphetamines it includes other stimulants like ecstasy as well. So this set of analyses examined whether concurrent amphetamine use at the commencement of opioid agonist treatment has any effect on treatment outcomes over time. So let's get started. So a significant proportion of people in opioid agonist treatment, that's methadone or buprenorphine, also use amphetamines. The established wisdom is that this amphetamine use reduces the chances of successful treatment outcomes. So, for example, cocaine among methadone clients is associated with poorer treatment retention and more heroin use. That's from American studies. So cocaine's a different drug and is not as common in Australia. Amphetamine use is also either before or during treatment is associated with greater social dysfunction and poorer psychological health. And that's from a bunch of Iranian studies that have looked at amphetamine use in OAT treatment. But no studies have really examined whether amphetamine use at the start of treatment has any effect to clients' response to treatment over time. So is it worse? Is it the same? Is it different? How is it different among these different groups? So using data collected routinely from electronic medical records, we wanted to ask, what's the impact of ATS use on clinical outcomes in opioid treatment program clients, specifically in relation to changes in substance use, health and well-being? So our research question was, for clients receiving opioid agonist treatment, does frequency of ATS use or amphetamine use at treatment entry have an impact on treatment outcomes over the first year of treatment? So we used outcomes data collected between July 2016 and June 2019 using the Australian Treatment Outcomes Profile. This Australian Treatment Outcomes Profile, or ATOP, is a brief substance use, health and wellbeing questionnaire administered routinely to AOD clients across New South Wales. This study basically, or the analysis, emulated a longitudinal cohort design which examines outcomes in groups defined by a single characteristic, in this case the level of amphetamine use before treatment. We used mixed effects models for repeated measures regression to test whether the rate of change over time in various important clinical outcomes was different based on level of amphetamine use when clients commenced treatment. So amphetamine use before treatment was categorized based on the number of days each client reported using amphetamine in the 28 days before they started treatment. There were three categories. That's no use in the 28 days before treatment started. That's 0 days of amphetamine use in the past 28. Low use, which was 1 to 12 days of amphetamine use in the past 28. And high use, which was 13 to 28 days of amphetamine use in the past 28 days. And remember, these are all OAT clients. So we tested the effects of start of treatment amphetamine use, how much people were using amphetamines when they started OAT treatment, on 7 different outcomes during the first year of treatment. That was amphetamine use over the first year, opioid use, cannabis use, alcohol use over the first year, psychological health, physical health, and quality of life. And all of these are measured by the ATOP. So the criteria for a client's data being included in the sample, I should point out here that we couldn't use data from 2 of the 6 LHDs that we got data from, and that's because these use a different electronic medical record system called CHIME, which doesn't have any encounter start and end dates, which made it hard to quantify when, periods of treatment. So there were 3,416 opioid agonist treatment clients in the 4 remaining LHDs during the 3-year period. So we are measuring change, so we needed clients with more than 1 ATOP. It could be 2 or 3 or 10, but we needed at least 2. So after removing the clients that only had 1 ATOP at the start of treatment, we were left with 2,267 people. ATOPs are for the previous 28 days, therefore any total encounters that were less than 28 days were not valid. So after removing these, there were only 1,000 left. The clients needed to have valid amphetamine data at baseline. So after removing the people who didn't have that, we had 951. The clients also needed 2 ATOPs during a 1-year period. And the reason we limited it to 1 year was because the numbers in the high amphetamine use at baseline group dropped too low after 365 days. So we limited it to that. So these numbers, I should point out, are different from the abstract, and that was due to a typo, so apologies for that. So this slide shows the numbers in various bins of time, basically. So at baseline, about 77% of OAT clients had not used amphetamines in the 28 days before baseline. So that's, you can see that in the none group up there. About 20%, or 185 out of 920, had used amphetamines sporadically from 1 to 12 days in the 28 days before they started treatment, and about 3% had heavy amphetamine use. That's 13 to 28 days use in the past 28 days. And as you can see, these numbers sort of drop off over time among this group of clients. In the 1 to 3 months after they commenced treatment, there were 77% as many ATOPs done as at baseline, 65% in between 3 to 6 months, 48% between 6 to 9 months, and 37% between 9 to 12 months. And I should note here that these are ATOPs done, not the numbers still in treatment. We actually don't know how many were still in treatment at this stage, and because we haven't really done that data linkage yet. So if a person had only 2 ATOPs in the second period, it could have happened in the first 3 months, or the 6 to 9 months, or the 9 to 12 months. So we could only just assume that the lower number of ATOPs at each stage reflected the lower number of people still in treatment, but that would basically just be an assumption. And note that the low number of ATOPs in the high ATS group at 9 to 12 months, we've only got 11 people. But also note that this reflects more the low numbers at the outset. There was only 27 at the start of treatment, rather than a faster rate of dropout. And in fact, this group had, as a proportion of the starting numbers, this group had a lower rate of dropout than the none and the low groups. So let's get to the interesting stuff, the change in substance use, health and well-being. Here are the changing outcomes over time. The solid lines are the mean level of outcome, the outcome in question for all the ATOPs administered within that time window. So the mean on ATOPs administered at baseline, the mean of ATOPs administered in the 1 to 3 months after the start of treatment, the mean on all ATOPs administered in the 3 to 6 months after treatment, and in the 9 to 12 months after treatment. So the yellow lines is the no ATS use at baseline group, blue is the low ATS use at baseline group, and grey is the high ATS use. Oh no, sorry, it's the other way around. Grey is the no ATS use at baseline, blue is the low ATS use at baseline, and yellow is the high ATS use at baseline. Now the dotted lines here are the actual predictions made by the statistical models. Now if we look at these models, we can see amphetamine use up here. We have sort of, surprise, surprise, the high ATS use at baseline group has a high ATS use at baseline. None of us saw that coming. But you can see that the differences in ATS use present at baseline reduced dramatically in the first 3 months. And then sort of more or less, and the differences are much lower throughout the remaining year of treatment. The same is true to a lesser extent when it comes to opioid use and cannabis use. You can see that people who are using a lot of amphetamines at start of treatment are also using more opioids and cannabis, but that over time, these differences actually diminish down to not very much. So alcohol use, it doesn't look like there's much difference in alcohol use based on people's ATS use at baseline. The health variables, it's hard to know what's going on here. There appears to be a general improvement in psychological and physical health, but no sort of noticeable group differences. The problem with these variables is you get range restrictions, which smush the means into the middle. As you can see, the scales are different here as well. The psychological, physical health and quality of life are on a 0 to 10 scale, whereas the substance use ones are just based on number of days used in the previous 28 days. So you can see here that across all the models, across all the graphs, the statistical models represented by the dotted lines are actually doing a pretty good job of predicting or matching the actual means. So that's a good sign. So the good thing about these models is that even though you're treating time as a continuous predictor, you can still get the model to estimate the differences between groups at single points in time, in this case at baseline, 6 months and 12 months. Now these tests of simple effects of group largely support what we could see in the graphs. For amphetamine use, the large average differences in amphetamine use at baseline, those still significant, have reduced dramatically by 6 and 12 months. So there's 20 days difference, 20 days difference at baseline, as you can see, but that's in the high, between the high ATS use group and the no ATS use group, but that has reduced to 4 days difference at 6 months and 2 days at 12 months. Similarly, there's 17 days difference between the high ATS use at baseline and low ATS use at baseline groups, but this is reduced to 2 and 6 days at 6 and 12 months from the start of treatment. So opioid use and cannabis use, amphetamine use at baseline was associated, once again, as we could see in the graphs, with significantly greater opioid use at baseline, but these sort of reduced down to non-significant at 6 and 12 months. And alcohol use, once again, as we saw in the graphs, amphetamine use appears to have little association with alcohol use. Maybe at 6 months here, but not large differences. So when it comes to psychological health and physical health, there's no significant differences between any groups at any time point. But with quality of life, we can see that those who weren't using ATS had significantly higher quality of life scores at baseline than those who did. But that these differences, once again, had disappeared by 6 and 12 months. So our findings suggest that OAT clients, people in opioid agonist treatment who use amphetamines when they start treatment, also tend to use more opioids and cannabis than non-users, but their use of these substances tends to reduce within the first year of treatment to the point where at 12 months, it's no higher on average than people who are not using amphetamines at the start of treatment. The quality of life of OAT clients who use amphetamines is poorer at the start of treatment than of people who do not use amphetamine, but that these differences also subside over time until, like substance use, there's little difference between the groups by the end of a year's treatment. So our findings suggest that opioid agonist treatments are associated with global reductions in opioid and cannabis use, as well as amphetamines, and improvements in general health and well-being. And that although using amphetamines is then associated with greater use of other substances and poorer quality of life, providing they stay in treatment, the prognosis for clients who are using amphetamines at baseline is not significantly worse than for the clients who are not. The fact that treatment is associated with similar outcomes for all clients, regardless of their ATS use at the start of treatment, is very encouraging. So the limitations are that the analyses were restricted to one fairly simple time invariant predictor, that's ATS use at the start of treatment. So if we get access to more predictors like data about the treatment provided to each client, for example, it'll allow us to build better models. So given the versatility of these models and the number of untapped sources of treatment and outcomes data in electronic medical records, the potential for us to obtain answers to questions of real clinical importance through routinely collected data is enormous. The last limitation is the number of OTP clients who had high levels of ATS use was quite low. But we're getting access to more data all the time, so hopefully this will be rectified in future. Thank you very much.
Thank you very much, and that's very interesting and encouraging. So we now move on to Krista Seafried, who will talk on clinical outcomes and measures used in randomized trials for pharmacotherapy for methamphetamine dependence. Over to you, Krista.
Thank you, Michael. I'd like to just open by acknowledging the traditional owners of the lands from which I'm presenting and pay my respects to Aboriginal and Torres Strait Islander elders, past, present, and emerging. Today, I'm presenting to you on treatment outcomes and measures in clinical trials of pharmacotherapy for methamphetamine dependence. My conflicts of interest are listed here for the 4 authors of this paper, and I'd like to acknowledge that it's a bigger piece of work, which was a systematic review funded by NCCRED earlier this year, and NCCRED receives funding from the Australian Department of Health. A bit of background, a health outcome is a change in the health of an individual or group of people, which is attributable to an intervention or a series of interventions. And most recently, the ICHOM standard set for addiction was developed, which lists some outcomes and measures, but focuses very broadly across various substance use disorders, as well as other addictive disorders such as gambling or internet. The US National Institute on Drug Abuse Clinical Trials Network also provides a list of common data elements to be included in clinical research studies. The use of inconsistent outcomes and measures could rather than inconsistent, could increase data sharing, capacity to meta-analyze across data sets, and improve study power and generalizability more broadly. So the methods for this presentation, we conducted a systematic review of studies examining a pharmacotherapy for amphetamine or methamphetamine use disorder or dependence from studies for all time points up to June 2019 that were published in English and that reported on an RCT of at least one pharmacotherapy. Studies were evaluated for design, methodology, eligibility criteria, sample size, pharmacological, and if included, psychosocial interventions, length of follow-up and follow-up schedules, outcome variables and measures, results, overall conclusions, and risk of bias. Outcomes were any reported impact of the treatment under assessment related to methamphetamine or amphetamine use, and the measures were how the study assessed the outcomes. So of course, once you define an outcome, a way to measure it needs to be identified. So we systematically reviewed 43 studies that met our selection criteria. They collectively enrolled over 4,000 participants and reported on 23 pharmacotherapies, either alone or in combination. And when we assessed the outcomes and the measures for assessing the outcomes, there were 55 primary outcomes used 93 times. And this was because some studies included multiple primary outcomes. And the disparate outcomes actually prevented us from meta-analyzing this data. 75 distinct secondary outcomes were included, inclusive of variations, and these were used 158 times. They were often used or defined differently to the primary outcomes of the same domain. The most common primary outcome and measure that was reported included abstinence, which was measured typically by urine drug screens and defined as abstinence based on weekly proportion of amphetamine or methamphetamine-free urine drug screens, or an overall proportion throughout the study time period, or a defined subset of time period within the study of amphetamine or methamphetamine-free urine drug screens. Craving was the second most common primary outcome, and that was typically measured via a visual analog scale. It was also most commonly the most commonly measured secondary outcome in the studies that we assessed. So why is this important? I guess one of the reasons is that we couldn't meta-analyze these data. And in fact, in terms of meta-analyzing the data, the studies had quite low retention rates. And so meta-analytics would have been useful to increase the power of those studies. And also the way that outcomes were named, identified, measured, and then assessed in the reports, because they were so disparate, left to sometimes conflicting or confusing data. So one example was adherence to the study drug. There were various ways of reporting the measurement of adherence. These included self-report or pill count. Pill count could be a direct count or averages over a space of time. Staff administered doses. So this is when a study drug was actually given by a staff member and could be recorded as administered. MEMS caps, which are an electronic monitoring system that's built into the top of a bottle for study medications, or sometimes study drug or metabolite in the urine or blood. Now, all of our studies assessed were randomized controlled trials, and the study drug or metabolite being measured in participants didn't actually account for placebos. There was no way of tracing whether people were actually taking the drug, whether it was placebo or drug under investigation, for example. And in fact, in studies using more than one method of measurement, low concordance in results were apparent across all studies. So that being, self-report being very high, but actual MEMS cap data or being low, or study drug or metabolite in the urine or blood being non-existent despite high self-report of administration. So as I mentioned before, in the studies reviewed, completion rates were very low. So the proportion of participants who did not complete the protocol was just over 38% of those who were randomized to the protocol. And the lack of consistent outcomes or measurement methods prevented meta-analysis of the results, which with no standardized approach means that important results such as safety were also sporadically reported. So two issues here. I guess the first issue is that we could improve power across a series of studies that are very low retention to create a more meaningful and generalizable set of data. Outcomes weren't always patient-centered. This is an issue particularly around abstinence versus reduction in use. Again, predominantly the studies that we reviewed focused on abstinence, which may not be a patient-centered outcome. with regards to safety, safety was very selectively reported. So even with publications guidelines, such as the consort statement, safety was very poorly addressed in the reports that we reviewed. So for example, only 3 studies, or 7% of the studies that we looked at, provided information on adverse events or serious adverse events, despite those reporting guidelines. So even in the setting where you have reporting guidelines to help you to focus your outcomes and standardized ways of measuring them, we're still not adhering to those guidelines in terms of reporting those data. Disparate outcomes and measures were also used to determine eligibility. So eligibility criteria varied widely. For example, heavy use of methamphetamine pre-enrollment varied from 7 days in the last 28 up till 28 out of 28 days. So this makes it, again, harder to synthesize results of various studies and various pharmacotherapies across those studies. I guess one important thing is that this piece is a little bit more of a report of what we found rather than a discussion of a solution. And I think ICHOM has really tried to make some headway there. Michael and Nicola Black have done a lot of work with the Australian contextual leadership of that ICHOM data. But I guess one of the things to mention is including in your current program of clinical research, including discussions with your colleagues and with other study teams and groups. We've had a few examples of this recently where we've been able to reach out to investigators looking at similar compounds elsewhere in the world and being able to discuss with them what outcomes they'll be using and how we can measure them similarly, so that suddenly a study that might be enrolling 20 participants per location can be amalgamated to derive some more meaningful data via meta-analytics later to determine outcomes. What did we do with this data? So we have published this data in a table as part of the larger systematic review, and we've also made that table available on the NCCRED website in terms of being able to discuss with colleagues and focus efforts around using consistent approaches towards outcomes and measures. I think it's really important to note and draw some attention to the various studies that were presented today. It was really great to see that people put slides up of their entire study procedures around what their primary and secondary outcomes were and what they were using to measure. So I know that David had an entire slide, so it's probably, having seen that in context, probably not very surprising that we discovered as many various outcomes as what we did and various ways of measuring them when you see an entire slide for one study, and then that varied quite a lot to what Eddie put up, of course, in a youth population versus adults. And Liam and Victoria also put up some slides with their study design. And so I guess it's just trying to start this conversation around how we can better sort of go into a cohesive research methodology with our colleagues to ensure that we're respecting our participants' consent to use their data and making sure that we get the most out of those data. So harmonization of outcomes or measures to produce results that can be synthesized by meta-analysis should be a sector-wide imperative to ensure better research synthesis. Reduction in methamphetamine or amphetamine use should be required for assessment of efficacy instead of just a binary abstinence definition. Reliance on extended periods of abstinence as a primary endpoint doesn't always reflect those participant-centered and focused important goals. And further work is really required to determine outcomes that are both clinically meaningful and meaningful to consumers. So further information through the publication or on the table on the NCCRED website to help sort of start a discussion when you're designing your research about how to go about these important questions. Thank you very much.
Thank you very much, Krista. Excellent presentation. And now over to Robert Sinclair, who is the Chief Executive of NADA and has spent some time reflecting and thinking on some of these outcome issues, and he's our discussant. Over to you, Robert.
Thank you, Michael. So yes, my name's Robert Sterling. I'm the CEO at NADA, the NGO peak body in New South Wales, and an NCCRED board member. I'd like to acknowledge the traditional owners of the land we're meeting on today. For me, it's the Gadigal land of the Eora Nation, and pay my respects to elders past, present and emerging. And I'd also like to thank our presenters in this session. So we know that outcome measurement is important to understand the impact of the services that we provide, and it's great to see the use of routine outcome data in real real world settings in the first two presentations. The use of outcome tools is obviously important in clinical trials, but we really need to see their use in real world settings being published and used to inform AOD treatment service and system improvement. Krista's review of measures used in RCTs provided some valuable insights, and I absolutely agree that we need to move towards a person-centered approach to outcome measurement. And Krista also mentioned the ICHOM set for AOD, and really great to see that Australia was well represented in the development of that set. And it will be interesting to see how these influence future research. So I think talking about outcomes more generally in Australia, I think there are some differences in tools used across public, NGO and Aboriginal community controlled treatment services. But I think we've come a long way in harmonising some of these tools. But what I think is really important is that there is broad agreement on outcome domains beyond abstinence, those being reductions in substance use and risk behaviour, mental health and wellbeing, physical health, social functioning or quality of life, and good to see the use of quality of life in the earlier presentations. I know that in the NGO services that I represent, they place a lot of importance of quality of life as an outcome measure in their services. And I know in some of our New South Wales community controlled services, they're looking at outcomes related to connection to culture for Aboriginal and Torres Strait Islander people accessing treatment. And just in reference to a question that was in the comments earlier, we don't routinely collect data on gender and sexuality, which is a gap in the data that we collect to understand outcomes with these groups. And I would encourage a review of the items in the National Minimum Data Set to include these. Outside of clinical trials, or perhaps not, I would say that there are still challenges in practice. We see good baseline data, and then we see a decline in the use at different points. So more common at exit, but less so at other progress points, and even less for post-treatment data collection, with lots of challenges for services to do good follow-up in terms of the resources required to do that. So we know that there's a lot of great work happening in this space in Australia. We're doing really well, but I do think that there is an opportunity, just building on Krista's last points, to bring together consumers, non-government, public OD services, community-controlled services, research and policymakers together across the country to work collaboratively to move towards a more consistent and person-centered approach, and also look how we can increase their application in practice. And we just need to make sure that those measures are relevant in clinical practice, but can also be used to inform service and system level improvements. And in terms of person-centered care, I think it would be great to see an increase in the value of experiences of care measures for people accessing treatment. Thank you. Back to you, Michael.
Thank you very much, Robert. That's an excellent summary. And I'd like to thank all the speakers for providing a very up-to-the-moment description of some of the outcome issues. Before you go, Robert, just to note some of the challenges of outcome measurement is particularly around if you've got low-level consumption, measuring change can be very hard versus high-level, and that's a big challenge in relation to showing impact and showing critical difference. I don't know, in your travels, when you were looking at outcome in other places, where you think Australia stands in relation to the international sort of...
Look, I think we're pretty well progressed. I mean, I think Australia has traditionally done very well in the AOD research space. My study in particular is looking at how we use client outcomes to measure performance of treatment services. And in my study, I found looking through the contracts of funded NGO services that less than 10% of performance indicators actually related to the measurement of client outcomes. So I think we've got a long way to move towards shifting that from more outputs and process-based performance measures to look at how effective we are at providing treatment services.
Well, that's a great note to finish on. Thanks very much, Robert.